right.
Yes.
Good. So good morning. This is a little weird. This is absolutely not how I expected to give my senior lecture 4 years ago. I honestly really can't believe that I'm giving my senior lecture right now. When you listen to these lecture series as a junior, it seems so far away and they seem so wise. And here I am in what seems like really no time and definitely don't feel as wise. So today I'll just talk about kind of my journey as a resident and a new mom in residency. Throughout the process, I'll talk about some experiences, some of my own experiences and some of the unique challenges of being a mom in residency. I'll talk about breastfeeding and challenges associated with being a resident and trying to breastfeed. I'll talk about postpartum emergencies, just because this is conference, and then we get a little bit more conferencey. I'll touch on things like postpartum depression, and then offer some tools and tips and strategies that helped me in the last 2.5 years. And then I'll also suggest some ways that you can be an ally to your colleagues, because you'll definitely have colleagues that will become mothers in residency and then and beyond. And obviously, I'll use this opportunity to shamelessly share pictures of my little boy. And to be honest, when I was kind of debating what to talk about for my senior lecture, I hesitated with this topic. I didn't want it to seem like being a mom had completely taken over my identity, that I really had nothing more interesting to share than kind of being a mom. I have other interests, medical pipeline programs, increasing diversity of emergency medicine. But when I really had to think about it, this really has defined pretty much almost the entirety of my residency. I've either been pregnant or been a mom since second year. So I really had to lean into it and just embrace that this was a huge part of me and something that I feel like I wanted to share. So my journey starts as a baby interns era. Second year, just trying to survive SICU. I found out I was pregnant. It was both exciting and extremely scary. A newly minted third year, I became a mom. After 5 really glorious months at home, thanks to our extremely supportive residency leadership, I came back to work as a resident mommy doc, sitting in the back of conference with my little boy. I had planned to give this lecture with him in my arms. COVID took that opportunity away from me. So you can just picture him squirming here. And by March of third year, I started experiencing some breastfeeding challenges and weaning from breastfeeding much earlier than I wanted to. That's me in Caldwell's office at Lutheran pumping. And here I am today, still really trying to just figure it out. So I worked clinically until the end. I looked like this. Ultimately, when overdue, had to be induced, labored painfully for hours, made no cervical changes. And then after about 15 minutes after getting an epidural, after what they said would be another 24 hours of labor, my son decelled and I had to go to an emergency C-section. He was thankfully born without any issues, and I survived a code 66 and a severe hypotension and a high spinal, where I pretty much couldn't breathe on my own for what felt like forever. And on 8/18/18, he was born at a massive 7 pounds, just kidding. And I became a mom. So obviously residency has its own challenges, and being a mom in residency has its own unique challenges. Those really start with your own negative self-perception. You have this idea that you're really not pulling your weight, that you're clinically weaker because you don't have time to read the way everybody else seems to be reading, #Robbie, and that you're just really, you're just not there clinically. And this is supported in qualitative literature. There was a study that showed that breastfeeding mothers were convinced that their breastfeeding was having a negative impact on their co-residents. But when you surveyed the same co-residents, they didn't think that way at all. And that really touches back to kind of the way we as resident moms feel that our participation is affecting the team. And these concerns aren't really put to rest when the literature suggests that these feelings of negative perception, self-perception, might be valid. Okay. There was a study done or a survey done amongst surgery residency program directors, and that showed that 61% of those PDs that were surveyed said that being a parent negatively affected female trainees' work. They created increased burden on fellow residents, and that they were less well than their male counterparts. So that definitely doesn't help. In Canada, a survey suggested that women felt less supported when they went back to work. A lot of this might have been contributed to the fact that you really lose that outward sense of parenthood once the pregnancy ends. You're kind of just back to the status quo, but really on the back end, you're dealing with fatigue and breastfeeding challenges and sick kids at home, and your new role in general. And then obviously our work hours are weird. We work days, we work nights, we work weekends, we work overnights. And it's pretty, at this point, there's a lot to suggest that mothers who work non-standard work hours, have children that have inferior cognitive and behavioral outcomes. They have worse sensory perception, memory, they have learning and problem-solving difficulties, they have inferior verbal communication skills and expressive language. They exhibit more negative behaviors like depression, anxiety. A lot of this can be attributed to inconsistent and poor quality of childcare arrangements. Moms who work these kind of hours might engage in fewer pre-academic activities like reading books to kids, practicing, doing homework. And then they're also more tired, more anxious, more irritable, more stressed. And these can also negatively affect children. And then in 13 and 14-year-olds whose parents work nights, it's been shown that they have increased risky behavior, things like smoking, alcohol use, increased sexual activity. And obviously, we don't want these things for our children, but we do have committed our careers to a career that has that. And it poses challenges for childcare arrangements. How do you piece together childcare when you go to work long before daycare opens and work long after the daycare closes? Do you do daycare and a pickup nanny or a drop-off nanny? Do you have a night nanny and a day nanny? Do you have a live-in nanny? Do you have a partner that can help you drop off your kids before or pick them up after? It can get really complicated. And then subsidies really leave out these special circumstances. They think, kind of childcare is a monolith and it's just daycare, but it can be much more complicated than that. Thankfully, CIR reimburses more flexible childcare arrangements. So those who are thinking about planning for a family, they do offer reimbursement, kind of just a lump sum, so you can just figure it out, which is really great. More employers should do that. And probably the hardest thing for me, in terms of challenges of being a resident mom, was really the guilt about working, guilt about liking to go to work, wanting a social life, wanting to go to post-shift breakfast, happy hours, journal clubs, and then also guilt about sleeping too much and not being with my kid, or not reading enough, or maybe taking time to read an article or prepare for something. So really, you really didn't win in any way. You really feel like you're failing in one respect and failing in the other. You really can't win. So I'm going to talk a little bit about breastfeeding because it was such a huge part of my postpartum journey. I really don't talk about it. I know I did a small morning report for those who were there, so I'm just going to touch on a few things. And fortunately for you, a little bit unfortunately for me because it's a little redundant, we got a really great talk by Dr. Joshi a few weeks ago, so I guess this can just function as a review. Obviously, the benefits of breastfeeding are really well documented. It's recommended within the first 6 to 12 months, either by direct breastfeeding or express milk. Benefits to children vary from giving antibodies, white blood cells, enzymes, hormones, growth factors, reduces the rates of neck, gastroenteritis, respiratory infections, otitis media, UTIs, and even later on in life, it has decreased because associated with decreased rates of obesity, diabetes, and some types of cancers. For mothers, it's also beneficial, lowering rates of breast, ovarian, and endometrial cancer. May reduce the risk of osteoporosis, cardiovascular disease, and diabetes, and it really helps you lose a lot of that pregnancy weight. Some could say it's akin to running a 5K every single day in terms of calories expended. So what happens with breastfeeding? Prolactin is necessary for milk secretion, kind of increases throughout pregnancy, but is inhibited by progesterone and estrogen. As those hormone levels drop off at the end of pregnancy, prolactin becomes uninhibited and allows for milk production. Suckling allows for the milk letdown and increased prolactin level, and then kind of that circuit allows for sustaining. The more you breastfeed, it's kind of a supply and demand, the more milk will be made. Kind of giving you the breakdown, there's lots of ways to pump if that's the route that a mother goes. Hospital grade pumps are big and really effective. More portable pumps are pretty much what the standard issue is at this point. They can be plugged in or they can be portable on a portable battery. Hand pumps, kind of are just classic, that's the one in the middle. And then kind of more passive ways of gathering milk is like when the baby's breastfeeding, this little doohickey here on the bottom, with that left, it's called a haka, and it just like takes the milk as you're like breastfeeding to not waste the milk that's coming anyway. And then self-expression, obviously. And so how often do you have to do this? You pretty much mimic your child's feeding patterns every 3 to 4 hours. If you go back to work earlier than 3 months, sometimes it's even more than that. And it depends on the woman how long it takes. Sometimes as low as 10 minutes, and sometimes as long as 45 minutes. And what happens when your colleague says, oh, I'm gonna go pump, I'm gonna take a pumping break? Pretty much they have to go get their pump from wherever they've stored it, in the break room or whatever. They put their kind of hands-free bra on or somehow fixate their cups to the breast. They turn on the machine. First there's a low suction, high speed frequency to let the letdown happen. And then it has to switch to a high suction, slow speed pump, which actually brings the milk down. You have to store the milk, clean the parts, or at least store it in a bag and then put it in the refrigerator to be clean when you get home. And then you have to refrigerate the milk. And all of that can take some time between breastfeeding and kind of pre and post. So, you know, it isn't like a 10-minute process where they say, I'm gonna, you know, like they're going to the deli to get food. They have to anticipate that they'll be away for a while and just be supportive of that. Oh, bless you. Out there. Obviously, breastfeeding comes with its own set of challenges. You know, gone are the days on the farm where you can just whip it out. You know, there's a lot of societal, cultural kind of stresses that people place on breastfeeding mothers. There's sometimes just a lack of understanding of what goes into it, financial disparities. Luckily, under the Affordable Care Act, Obama made it kind of mandatory for breast pumps to be made available to breastfeeding mothers, or rather to expecting mothers at no cost or covered by insurance. But it can be emotionally challenging. It can be physically challenging. You know, mastitis, between mastitis and clogged ducts, and sore nipples. You need to be crazy hydrated, and you have to take in a lot of calories to be able to sustain it. But some mothers do it, and for a long time, and even they get shamed for it. So what can you do as a colleague? You can normalize the behavior. You can genuinely ask with interest if a female colleague is breastfeeding after they come back from maternity leave. And then kind of already preemptively ask when they might know if they're going to need to step out. Most of the time they'll have pumped on the way in, and they'll know, kind of have an idea of when the next time they need a pump is. So you can already kind of preemptively start picking up maybe a few more patients, or asking what you can help with some of the patients that they have so they can go do that. And if you're going to get some food, ask them if they want something too. They might be embarrassed to take a pump break, and then also if they're hungry later, take a food break. Because they're running in and out, and maybe they didn't bring food with them to kind of do two things at once. We're not perfect. And just save the lame jokes and commentary. It's just not cool. Just be supportive. Our field is supportive of nursing mothers. They endorse that all hospitals should have a sanitary room that's not a bathroom to be able to pump, that's close to the emergency department physically. And they kind of show that, you know, this could be multiple times in a shift, especially if you're working 12. You're going to encounter breastfeeding patients in the ER. They'll have painful and sore nipples. You can offer lanolin cream as a way to ease those troubles. Low milk supply, they'll come in concerned about that. First thing you can do is weigh the baby. If the baby's growing great, you can A, offer reassurance, and B, offer ways to increase the supply. Eat more, drink more, take in more calories, offer the breast more, pump more. They might come in complaining that the baby just is eating every 15 minutes and they're crying every 15 minutes after that. This might be what they call cluster feeding. This is usually a sign of growth, like a growth spurt. You just offer them reassurance, and pretty much the most important thing is to, do a depression screening. When they're in these kind of periods, it can be quite overwhelming, lack of sleep, and you want to make sure that you're catching, those who could benefit from psychiatric help. You're going to deal with engorgement. You can offer warm compresses, telling them to self-express in the warm shower, similar with a plug deck. For fungal infections, encourage hygiene, avoiding high sugar diets, and then they might come in concerned about nursing strikes, and eating less than normal. Again, weigh the baby. If the baby's still growing fine, offer reassurance. So this can happen, but if days start turning into weeks, then this might be a sign that the baby's starting to self-wean, and mom's just gonna have to figure out another way to feed their baby. They can have breast and nipple size challenges, not latching well, just not feeling like they're getting the hang of it. This is a really amazing resource that's free and international. It's called La Leche League. They have a website. I encourage all of you to know it so that you can properly direct people who could use it. And then obviously exhaustion. It's high calorie deficit. It's painful. It's hard, and sometimes parents will feel, moms will feel like they're stuck, like no one else can feed the baby. They'll experience things like sadness, depression, and judgment if they want to stop. So really just offer depression screenings and support more than anything. The breastfeeding child can experience breast milk jaundice, which is essentially an indirect hyperbilirubinemia that will occur in the first week of life. It generally does not cause kernicterus. We don't really know what it's caused by, but it's partially to be caused by inflammatory cytokines in the human milk and the presence of growth factor. Breastfeeding jaundice is essentially the baby's not getting enough milk and it's a volume contraction. Moms can supplement and then just and try to increase the supply as they improve the latch or the supply. So talk about postpartum emergencies. We'll start with a case. 28-year-old female, she's 41 weeks pregnant. She comes in active labor. After a few minutes of pushes and chaos, she delivers a healthy baby boy. And then all of a sudden her vitals just tank. She's tachycardic, she's hypotensive. So now what? I really want to think of your 4 T's. Yeah, you're right. So, exactly. So uterine massage, when we're thinking about uterine atony, which is the most common cause of postpartum hemorrhage, trauma of the GU tract, retained products, and coagulopathies. So obviously, first you want to think about your ADC IVO2 monitor. You want to get your fluids on board, blood products readily at hand, your TXA, 1 gram IV over 10 minutes, and then you can give your second dose 30 minutes later if they're still bleeding. And you want to get OB involved, obviously early, and goes without saying. So one thing you feel like we don't really talk about much, but you really need to be aware of that can happen is something called uterine inversion. This can happen with the kind of overly eager traction of the placenta before it's ready to detach. Pretty much you'll see the uterus kind of bulging either out of the cervix or out of the vagina completely. You want to reduce this as quickly as possible since the cervix kind of contracts pretty soon after birth, and it can cause like a constriction ring. So you want to pretty much just grab the uterus and push it all the way back. If the patient is getting uterotonics like oxytocin, you want to stop those and maybe even offer or start some uterine relaxant medications like nitro, mag, and trimethylene. And then once it's reduced, you want to fundal massage with bimanual massage, and then also give oxytocin. And then if the placenta, for whatever reason, is still attached, then at that point you want to start delivering the placenta. So talking about delivering the placenta, and we're going to see a lot of extramurals in our career. Don't be overly aggressive. Like, these things will detach on their own. Copyright Review kind of did a look into kind of expectant management versus active delivery of the placenta. Not really quite clear. what's better, but you have to start thinking of, there are negative things of trying to really aggressively. So unless the mother is, like hemorrhaging out, which then, you can be a little bit more patient. So meds, I don't know if you want to take a screenshot of that and just have it in wherever you keep your important med list things. Uterotonic meds, oxytocin, Cytotec, Methergin, these will all help kind of contract the uterus while you're doing bimanual massage. You can also use a back balloon, which is essentially a massive pulley that you fill with warm fluids in order to help stop the bleeding while you wait for definitive management. So trauma to the GU tract, you want to try figure of eights. Obviously, if it's very high up and close to the cervix, they may need the OR. You can pack and stabilize while they head to the OR and drain any hematomas greater than 4 centimeters. Serena Williams had a large hematoma that they found postpartum, but then she also had to drain. She had lots of stuff, poor thing. And also retained products, these need to be removed in order to help uterine contraction. And then you want to obviously reverse any coagulopathies. You'll do labs and you'll replace any appropriate blood products. And obviously if all else fails, IR or the OR. Another case, pretty much the same patient. So all of a sudden you deliver this boy and again, hypotensive, tachycardic, they've got increased vaginal bleeding and they're also bleeding from their IV site. You really want to think of amniotic fluid embolism. It usually happens during labor or pretty much right after birth. They'll go into respiratory distress, pulmonary edema, hypoxia, they'll be altered, and they can go into DIC. This is an absolute can't miss diagnosis. The mortality rate is extremely high at about 80%, and then 85% of survivors have neurologic sequelae. So definitely want to have this on your differential when you see a postpartum hemorrhage. Occurs in about 2 to 8 per 100,000 deliveries, and it's responsible for about 10% of maternal mortality in the United States. Risk factors are C-section, advanced maternal age, abnormal placental implantation, uterine rupture, eclampsia, and trauma. It's pretty much supportive care. If they're hypoxic, you intubate. If they're hypotensive, you support their blood pressure, and you try to avoid hypoperfusion, placing the patient on the left lateral cutis. And then obviously if the baby's not delivered yet, you want to get that baby out of there. So similar patients, pretty much vitals are significant for fever. They're 4 days postpartum. They're complaining of chills, nausea, vomiting. What questions do you want to ask? Kind of just general symptoms, cough, urinary complaints, belly pain, nausea, vomiting. You want to have things like URIs on your differential, respiratory tract infections, pneumonias, pyelo, intra-abdominal abscess if they have a C-section, thrombophlebitis if they have prolonged IV placement. But you're most worried about postpartum endometritis. It's often polymicrobial, and the mortality rate is highest 4 days after delivery. So you want to have that on your differential. Pretty much if you're postpartum and you have a fever, you need to think of GU infections. They'll present with fevers, foul smell and lochia, but not always. Leukocytosis, uterine tenderness, and sometimes just a little bit of discharge if it's group B strep. And the risk factors are extensive. Pretty much you treat this with antibiotics, although you want to check for retained products before you do, and manage that as you would. Next, Kate. You have a 29-year-old female. She comes in. Is that Vicky? What up, Vicky? 29-year-old Black female. She comes in pretty much her BP is significant for hypertension. She's 4 days postpartum for a scheduled C-section, for prior C-section. She's got a headache. She's got nausea, vomiting. So what questions do you want to ask?
Did you have preeclampsia?
Exactly. For the 5 people here. Anything else you want to? This is so depressing.
History of hypertension?
Yeah, sure. History of hypertension. Do they have preeclampsia? And then your standard kind of you're just coming in with a chief complaint of headache, standard headache question. You know, is photophobia, neurosymptoms, you know, the onset of symptoms, did it happen right away? Was it gradual? History of headaches? Because your differential will be extensive, especially, you know, it'll have the run-of-the-mill things like tension headache, migraine headache, but, you know, you'll also have specific things that you think of more in the pregnant patient. Is she having, you know, preeclampsia? Did she have a hemorrhagic stroke? Does she have a cerebral venous sinus thrombosis? Carotid or vertebral artery dissection? These are all things you're going to have on your differential. And then specifically to the or recently pregnant patient, do they have an epidural? Is this a post-epidural spinal headache? Obviously, you're most worried about kind of the things that will kill you. I put this up here just to kind of highlight that there are a lot of things that should be on your differential. And so what are your next steps? It could be as little as nothing if it's just, you know, classic migraine, to an LP if there's an element of altered mental status and fever, CT if you're thinking stroke, hemorrhagic stroke, and then MRI if you're thinking of the more dangerous cerebral venous thrombosis and ischemic stroke. And then for specifically for post-dural puncture headaches, you want to offer bed rest, analgesia, and this blood patch. I've never done one of these, and it's really exactly what it sounds like. You take the patient's blood sample and try to inject it into the epidural space, pretty much exactly where the epidural was. And it's not quite sure how it works, but it's hypothesized that it just kind of tamponades the leak and helps restore CSF volume. And similarly to any other patient, you want to treat their headache. You can offer opioids, although it's not the best. And then aspirin you want to avoid for the theoretical risk of raise. Another case, 29-year-old female, pretty much coming in with headache and ankle swelling, hypertensive, 4 days postpartum, C-section, just coming in with headache and ankle swelling. Things you want to ask?
Preeclampsia.
Preeclampsia. Yeah. Do they have a history of preeclampsia? You know, what are their other medical problems? Do they have, you know, do they have a history of CHF? Kind of standard questions. What's on your differential? You want to think as broadly as, you know, preeclampsia, trending towards eclampsia, you know, could this be help? These things you want to think about. And then obviously those would be the ones that you'd be most worried about. Postpartum hypertension is described as systolic blood pressure over 140 and diastolic over 90. Blood pressure naturally rises over the first couple of days postpartum, and it'll peak on days 5 and 6. And this could be probably because of just shift in total body volume, water, after the pregnancy. Yeah, could be as simple as that. Preeclampsia is hypertension plus proteinuria. Warning signs are things like stomach pains, headaches, nausea, swelling, shortness of breath. You want to have this on your differential for sure. And then as bad as preeclampsia, kind of on the spectrum. You'll have preeclampsia plus then signs of worsening organ damage like seizure, liver failure, renal failure. And late postpartum eclampsia is described as kind of like seizures up to 48 hours after delivery, up to 4 weeks. So you should keep this on your differential long after baby has been born. Help, just to review, hemolysis, elevated liver enzymes, and low platelets. If your suspicion is high, you should be doing labs on these patients. Symptoms, they can come in altered, with neurologic findings, abdominal pain, a rash, complications associated can be as bad as DIC, renal failure, pulmonary edema, capsular hematoma, liver hematomas, and retinal detachment. Obviously, you want to treat DIC as aggressively as possible with FFP. Press is then kind of the most extreme, kind of seen on the spectrum, but you can also get press in other kind of hypertensive encephalopathies, headache, confusion, visual changes, and then the MRI is kind of the deciding factor. You'll have white matter abnormalities, which is essentially from the vasogenic edema and the increased ICP. So you want to get vital, CT, if you're concerned for the headache, basic labs, including a baseline MAG, including uric acid, including PT-PTT, and then an MRI if you're concerned about press and urine protein to kind of diagnose the preeclampsia. So this is a little bit of a downside. So treating, there's not really shown any real benefits in terms of aggressively treating hypertension in postpartum hypertension to avoid then going into preeclampsia and eclampsia. Although you can treat these hypertensive episodes, hydralazine and labetalol. Preeclampsia, you want to give IV labetalol, IV hydralazine to help lower the blood pressure. And then to prevent seizures, MAG, and then ultimately, obviously, if they're seizing, you want to give benzos. Uterine curettage, plasma exchange, and cerebral angioplasty have also been shown to help decrease seizures. And then if you're already in at PRESS and HELP, you want to aggressively control the blood pressure, prevent seizures, platelet transfusions if you need, and then you want to think about subscapsular hematomas if you're noticing increased abdominal girth and hypotension. Another case, 29-year-old Black female. She's coming in with generalized weakness. She is pretty much that's her only complaint. She's also complaining of a little bit of cough, blood pressure, her vitals are as shown. She's also 4 days postpartum. She also has a headache with some ankle swelling. What questions are you asking? Similar to what we already discussed. What's on your differential for a patient who's coming in with weakness, postpartum? How much weakness?
Heart failure.
Yeah, well, thanks. Yeah, right. You want to think about other things like anemia, PE, URIs, MIs, postpartum fluid overload. Are they just depressed in their week? What you're most worried about, right, is postpartum cardiomyopathy. Etiologies include inflammatory cytokines, myocarditis, abnormal immune response, familial disease, or gestational hypertension. Risk factors greater than 30, being of African descent, having multiple fetuses, and then having preeclampsia, eclampsia, postpartum hypertension, and cocaine use. They might come in just with the basic symptoms of cough and fatigue or just vague chest discomfort. Might have some swelling in the legs, which you might dismiss as just regular postpartum swelling or residual preeclampsia. They might come in with orthopnea. You just want to have this on your differential. So next thing you do is just labs, and the most important thing would be an echo. You treat this the way that you would treat any heart failure with oxygen diuretics and early management. So 2 more cases. 2-month-old baby boy. They come into peds with mom. Baby's fussy. I'll save you having to Google it, but these are normal blood pressure, normal vitals for this kind of a baby. Pretty much the HPI is just that they woke up fussy, woke up 2 times this evening when normally they just wake up 1 time this evening, but the review systems on the baby is completely normal. Feeding well, looking well, no fever, no chill, no signs of that there's anything wrong with the baby. You'll see these patients in peds, and you want to make sure that it's not mom that is actually the patient in this case. It's extremely common. It kind of runs on a spectrum. Baby blues are really normal, kind of attributed to the hormonal shifts after pregnancy. Postpartum depression, we're talking about it more and more and more. Can range from 20% of postpartum women to as high as 50%. Low-income women and immigrants are particularly at risk. And then it can progress to postpartum psychosis. This occurs in approximately 1 to 2 out of every 1,000 births. Can happen quickly, within a few days after birth, but you need to keep an eye on your differential for up to a couple weeks. It's considered a psychiatric emergency, and you want to act on these patients quickly. They might be frightened. You want to really normalize their behavior. Postpartum moms really are trying to keep it together, make it look like they've got it. So you really have to be sensitive on how you approach these patients and be sensitive to how they might be feeling. My sister actually suffered with postpartum psychosis. Probably was the initiating symptom or kind of event that her schizophrenia kind of reared its ugly head. But it presented as postpartum psychosis. Happened a few days after birth of her last child. And it was devastating for our family, but we got through it, and she's doing much better. So next steps, you want to obviously admit if necessary. You want to give the appropriate referrals, therapy, social support, and antidepressants if they need it. So last case, you have a 6-month-old baby boy, pretty much the same presentation. Woke up 2 times instead of really waking up 1. Mom seems super anxious about it. You also want to think of post-feeding depression. This is something that's really not talked about very often, but it really is time that we start talking about it. You know, we really focus on the maternal health, the mental health of mothers right after birth, but you know, the hormonal shifts that happen during weaning can really tick a mother into delayed postpartum depression, especially when the weaning happens much earlier than the mother would have wanted. If they have a work schedule that doesn't allow it, there's some kind of a stressor, they're ill, they were separated from the child and unable to pump, for whatever reason, if it happens prematurely and too quickly, it can really precipitate post-weaning depression or delayed postpartum depression. Pretty much presents quite similarly to postpartum depression, although it could also just manifest as anxiety. I'm gonna get real deep here and say that I experienced kind of what this is describing. I went back to work at 5 months, pumped really aggressively for the first 3 months back at work, but then it just got too much. I was at Lutheran. It was really hard to pump regularly, to be away from the team. You know, you're in a different environment where they don't really know you, you know, the way that your family knows you here. And my milk supply jumped off really quickly, and it was really rough. It manifested for me more in the form of anxiety, less so depression, less so sadness, but it was crippling for a really, really long time. And you know, it's a process to like kind of recover to who you were. Obviously, similarly, you want to admit when necessary, mental health referrals if you need it, and then therapy, social support, and antidepressants similarly. We're talking about maternal health a lot more lately. Serena Williams had a really traumatic birth experience and kind of wrote articles and got the conversation started, especially maternal health among Black women. In 2018, kind of the rates of maternal death, they kind of republished them, were the highest among the developed world, 17.4 deaths per 100,000 live births. Worse with older women above 40. They're 7.7 times more likely to die compared to women under the age of 25. Maternal death rates among Black women more than double that of white women, and then 3 times the rate for Hispanic women compared to white women. It's an issue. So what can we do? We can advocate for our patients. We can advocate for each other. We can support each other, make the appropriate referrals. We can advocate for policy changes. Things like extending Medicaid, pregnancy Medicaid to a year postpartum to kind of capture those women who are dealing with, you know, breastfeeding challenges and postpartum depression. And then support innovation like the Mommy app, which is essentially is something that Serena Williams is investing in order to kind of help healthcare providers connect postpartum women with the appropriate services. As promised, that's my little munchkin. I'm talking about those heavy things, and I'm just going to talk a little bit about things that have helped me. Pretty much, I say this a lot, if you work with me clinically, I try to cognitively offload everything. You try to use physical actions to help you process information to kind of reduce cognitive demand. And we do this all the time already in the ER. We use things like flow algorithms and ACLS protocols to kind of not have to have those things memorized in your head. You have them kind of outside yourself that you can refer to. There's no shame in using checklists and algorithms to help you kind of cognitively offload. You can set reminders on your phone for repeat lactates and, you know, reassessments. You don't have to keep these things all in your head. Algorithms, you use algorithms because complexity equals increased intrinsic cognitive load. So the more complex things are, the more it takes to kind of process it actively in your head. So you want to use aids, things like the Broslow tape. There's no need to memorize exactly everything when you have these external aids to help you, and things like MD-Calc. You know, we don't really multitask. I think somebody sent it, Dr. Benson sent an email out with EKGs. You know, we don't really multitask the way we think we do. We do a lot of tasks really quickly after each other. So you want to politely kind of defer like if tasks are coming at you in a bunch of different ways, politely say, I want to give you my full and undivided attention. Let me finish what I'm doing right here, and then my attention is all yours. Or let me accept this order before I answer this phone call. Or delegating to the people around you. Do you mind grabbing that phone call for me and telling them to hold on while I finish what I'm doing right now? It'll take me a second. Or can you take that abnormal value for me? You can keep a list of uncompleted tasks, things like your notes that you haven't finished, or when we were in Quadramed and it used to crash and you had no idea who your patients were, who you wrote a note on, or who you dispoed, then I started a checklist on who I still needed to write notes on, and that still continues today. And talk out loud. Talking out loud, kind of group processing is very powerful. And then also just in general, if you think you don't have time for anything, it's gonna kind of clog you up to not effectively be able to think about the things that you do have. It's called response to scarcity. If you think you have no time, then you're really gonna have a difficult time processing things. So take a second, clear your mind, have your walk-up song, think out loud, use breathing techniques, things like stacked breathing, kind of take a deep breath in, hold it, exhale, take a deep breath in, kind of these stacked breath or box breath taking, stacked breathing. These are all things that kind of like help calm your mind and be able to do tasks more effectively. And use your intuition, but obviously know that it has its limits. If something doesn't make sense, Kelly always says, you need to ask more or better questions, or you need more data points. Trust that if something doesn't sound right, it probably isn't. And in life, really use, I use these cognitive offloading techniques. Things like lists, tasks on Google Tasks. I use many alarms. I do something called radical scheduling, which if you look at my schedule, it looks quite scary. But I literally plan out everything in my day, including sleep and commute time and shower, so that I really get a sense of what my free time actually looks like, what my time to do my shallow work, or my responding to emails, and my deep work, like my residency requirements, or the things that I'm passionate about. You schedule that all in, and you get a better sense of what you have time for. You offload things like groceries as a resident. Amazon Fresh is probably the best thing that I've ever done. I do groceries on my way to work or on my way home from work, and it's in front of my door when I get home. I don't have to think about these things. With delivery services, subscribe and save diapers and wipes, they just appear because I pre-plan them, and it's amazing. Laundry outsourcing I've done since I was a medical student. It's probably the best investment I've done with my time. Instead of spending 4 hours at a local laundromat, I have somebody do it before I drop it off on my way to work, and it's done for me. And then obviously I'm very fortunate that I have a nanny, so I can leave work at 6:30 in the morning and not have to think about, is my nanny, going to be on time? Is there somebody to take care of my kid? I can just walk out the door knowing that my kid is safe and he's still on his crib. So I have a live-in nanny, which is fortunately for me the best thing that I could have done in residency. So like I said, I task everything. I'll pull this up, but pretty much I start with like the basic stuff like sleep and commuting and my work schedule, and then I add in extra things like tasks with deadlines, my shallow work, my fun stuff if there's an event in the week, and then you never cancel anything. You always reschedule them. I'll pull it up later. But I just want to give a huge thank you to Dr. Smith, who's been my Shira the last more than that, 7 years since I've known her, and everyone else in the ED department, especially Dr. Willis, who's been there for me this entire process as a new mom.
Thank you, Sarah. I think this was such a beautiful personal, thank you so much for sharing. I think these are really great tips for anybody in times of stress, which I think is really what we're approaching. And so I think being patient with each other and speaking out loud and explaining things clearly and saying, can you remind me, or will you help me? Making lists, give yourself a break. We're heading into a hard time. Yeah. And I think these are great tips just for life. And this is really profound time in my life too. So thank you for sharing.
Yeah, so I just really want to thank everybody, obviously Stephanie and Dr. Jane Kim and Dr. D'Souza, who's surprisingly an expert on wellness. You should ask him about it. He really does have some profound things to say. He'll hate me for saying that. And obviously my family, like, I really couldn't have done it without you guys. I miss you a lot. My advising family, especially the OG Kelly family, I'm gonna miss kind of just being able to lean on you in real time, but I know this isn't goodbye. This is just I'll see you later, like in Hawaii with Derek or Miami with me. We'll see each other at weddings. Here's looking at you, Eric. Baby showers, baptisms. You guys were my rock, and I'm so grateful for you all, for my family that I've made here. This loser. And obviously, this is my whole world. Everything I do begins and ends with that. He's the best. And my nanny, Claudia, who I am eternally grateful for, and the village that I nanny share with, and that live in my building, who have become friends, and who I am also very grateful for. And then obviously the best thing that I've ever did in my life was choose to do life with my husband, Jaime, and I just want to thank you all.
Sarah Jones saved my family's ass when I moved here. She had never met me. She had never talked to me. She offered me her apartment for my entire family to live in because we could not find an apartment. Nobody would accept our applications. This woman has understood family even before she had.
Me too. I didn't even have a place to live, and Sarah was like, "Come live with me. Take over my apartment. You can have it. You can afford." So I got to live with her in 2 of her apartments.
Seriously.
Oh, thank
Thanks, guys. Just to give you an idea.